Thank you so much for this warm welcome, respected seniors and my dear colleagues. With your permission, I begin the presentation of today's topic titled Obeticholic acid placement in the clinical practice. Now, at the very onset, it would be a good place to go back to our roots and really understand that in the Indian scenario in the present day, be it a tier 1 city or a tier 2 city or tier 3 city, this rapid surge in the reported reports of hepatomegaly with grade 1 or grade 2 or grade 3 fatty changes, and the sheer rise in the number of diabetics, the snowballing of the number of diabetics throughout the world as also in India, and the snowballing of the number of fatty liver patients, if you might call it that, which would be having an entire gamut covering the spectrum of non-alcoholic and alcoholic fatty liver disease, non-alcoholic steatohepatitis, and subsequently cirrhosis, and unfortunately, certain cases, hepatocellular carcinoma. Will really discuss about identifying cases of non-alcoholic fatty liver disease, diagnosing cases of non-alcoholic fatty liver disease, diagnosing cases of non-alcoholic steatohepatitis, and we will also take a step back to evaluate our pharmacological management in such patients, because unfortunately we are keen to believe that pharmacological therapy is the cornerstone of management of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, which in reality it is not. It is the non-pharmacological therapy that is the cornerstone or crux of therapy in the management of non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. So we'll try to understand and assess the role of the non-pharmacological interventions. We'll try to assess and analyze the role of pharmacological interventions, including but not limited to obeticholic acid, and much more importantly, we would want to identify the specific group of patients having non-alcoholic fatty liver disease who are likely to benefit from the pharmacological therapy along with the non-pharmacological therapy. Now, any patient of non-alcoholic fatty liver disease and any patient of non-alcoholic steatohepatitis, both of them essentially metabolic derangements, and both of them essentially a part of that wide spectrum of insulin resistance. But not all of them are to benefit from pharmacological therapy, but all of them are going to get a benefit from non-pharmacological therapy. So we'll define non-alcoholic fatty liver disease, we'll define non-alcoholic steatohepatitis, we'll define the group of patients who are likely to benefit from the pharmacological interventions. Once again, a very important aspect would be the management of diabetes mellitus, particularly diabetic dyslipidemia, and diabetic patients with the non-alcoholic fatty liver disease. We would call it the diabetic liver. This entire gamut, we might call it a global pandemic as well. The world has approximately 425 million diabetics, 2017 IDF data. Approximately 430 million adult diabetics, 2019 IDF data. And India has approximately 77 million adult diabetics. And not only that, in the next few decades, the numbers are only going to get worse. By 2045, the world is expected to have around 700 million diabetics. India is expected to have approximately 134 million diabetics by that time. The global numbers, with a major contribution coming from India and China and United States, and also our neighbors Bangladesh and Pakistan, would contribute mainly to this huge global burden of adult diabetics and this huge global burden of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, and unfortunately in certain cases cirrhosis, and in some cases hepatoma as well. So the story is grim, the scenario is grim, and with this understanding, with the knowledge of how big the sheer numbers are rather than the severity, how big the numbers are, with this understanding, we will now define the non-alcoholic fatty liver disease. So accumulation of fat in the liver in the absence of recent or ongoing intake of significant amount of alcohol intake up to 20 grams per day, both for males and females. In fact, NICE guidelines would recommend less than 20 and 14 units per week subsequently for males and females. We do know that the male population have a higher metabolism of alcohol, females have a lesser threshold for alcohol metabolism, but that significant amount of alcohol for either gender would be approximately 20 gram per day for both males and females. If that is absent, then and only then you can go towards diagnosing non-alcoholic fatty liver disease rather than an alcoholic fatty liver disease, a spectrum of the alcohol use disorder. So this non-alcoholic fatty liver disease on pathophysiological basis can be divided into the primary causes and the secondary scenarios. Primary would be in cases where the secondary causes of hepatic steatosis have been excluded, and secondary of course would be cases where the secondary cause is present, be it hepatitis B virus, be it hepatitis C virus, various inborn errors of metabolism including Gaucher's disease, including mitochondrial disorders, galactocerebrocytosis and all that, liposomal storage disorders, also total parenteral nutrition, particularly in patients who have a prolonged ICU stay, various medications, surgical procedures. We do know about the anti-tubercular medications producing liver injuries. We know isoniazid does that, we know rifampicin does that, and so on and so forth. Multiple other medications as well, certain poisonings, certain chronic poisonings are important aspects of non-alcoholic fatty liver disease. The fat deposition in liver or the macrovascular steatosis that occupies at least 5% of the hepatocytes, at least 5% involvement, would clinch you the diagnosis of non-alcoholic fatty liver disease. However, simple steatosis, presence of fat in liver without the presence of lobular inflammation on histology, is another aspect. Kindly note, why are we trying to differentiate between this rather high 5% with simple steatosis? Your patient of simple steatosis would of course be having the indication of being on lifestyle modification, weight loss, graded graded aerobic exercise and so on and so forth, but more often than not a patient of simple steatosis would not be a candidate for pharmacological intervention. Non-alcoholic steatohepatitis or NASH, here the steatosis and inflammation are associated with the presence of one or more of the following three additional features on liver histology: the ballooning of hepatocytes, the mallory-hyaline bodies and fibrosis. Now kindly note, whenever we are talking about histology, what do we mean? We are talking about liver biopsy. Now I practice in a tier 2 town. I believe many of the audience and many of my colleagues and seniors attending this session would agree to the fact that in our tier 2 or tier 3 town, actually putting up a patient for liver biopsy is a very cumbersome, often difficult, often impractical approach, but we would like to highlight on the exact theoretical basis for the diagnosis of non-alcoholic steatohepatitis. We will also understand that this non-alcoholic steatohepatitis would be a case. Now, what is the pathophysiological basis of non-alcoholic fatty liver disease? The pathophysiological basis of non-alcoholic fatty liver disease, more often than not, would be insulin resistance. So much so that technically it's almost a part of metabolic syndrome. Your non-alcoholic steatohepatitis is the subsequent derangement of the non-alcoholic fatty liver disease with inflammation, and that inflammation on your histopathological examination would be found as ballooning of the hepatocytes or mallory-hyaline bodies or fibrosis. Yes, it's not that any patient of non-alcoholic fatty liver disease with certain minimal derange would be advised liver biopsy, not that. Particularly in the present scenario, we have the different types of elastography, particularly the hepatic elastography under the brand name FibroScan. As we know, it's a tool that is now a part of even tier 2 and tier 3 towns. In fact, even where I practice, there's hepatic elastography, FibroScan as we call it. It's now a part of our armamentarium. It has of course made our lives much easier. So actually selecting patients for liver biopsy becomes infinitely easier compared to the previous days. Moving on, now global prevalence, and this is what we are talking about, a huge global prevalence of non-alcoholic fatty liver disease. Overall prevalence of non-alcoholic fatty liver disease is 25% remarkably high. The world has a population of 7 billion and 25%, can you believe this? 150 million people with non-alcoholic fatty liver disease. It is that high. Prevalence in Asian countries, if anything, we have a higher population of patients with non-alcoholic fatty liver disease. As you can see in the Indian scenario, one of the highest prevalence among the Asian population, and we basically are ready for this. We know that insulin resistance is higher in the Southeast Asian population. We know whatever category you look at, whether a patient of say gestational diabetes mellitus, now in them, when you are projecting the patient for screening, we know that Southeast Asian population itself is a risk factor for gestational diabetes mellitus. It is that remarkably high in the Southeast Asian population, and that would include India and China, India and Pakistan and Bangladesh, the Indian subcontinent, if you might call it that. We also know that in the Indian scenario, when we look at diabetes mellitus, we know that approximately 95% of our diabetics, adult diabetics, have type 2 diabetes mellitus. Now, in our Western Caucasian counterparts, what is the incidence and prevalence of type 1 diabetes? More than 10% have type 1 diabetes mellitus. In the Indian scenario, we know type 1 diabetes mellitus is very low. So, essentially, insulin resistance and our abdominal obesity, our pear-shaped obesity that we keep on talking about, our high waist to hip ratio, WHR, the waist to hip ratio that we keep talking about, and not only that, in the Indian scenario, obesity, in fact the Southeast Asian scenario, obesity is defined, not obesity, overweight nature, overweight is defined as a BMI of more than 23. For our Caucasian counterparts, it is 25. Our abdominal obesity and our incidence of type 2 diabetes mellitus as a relatively younger age, our risk of microvascular and macrovascular complication at a much younger age occurring about 1 decade earlier, that is the scenario of our Southeast Asian population, the Indian subcontinent. So NAFLD epidemic in Asia: obesity, metabolic syndrome, dyslipidemia, sedentary lifestyle, Western diet. So this would be the 5 bullets that are producing this calamity of very high prevalence of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis in our case. So prevalence of non-alcoholic steatohepatitis in patients with biopsy proven NAFLD is as high as 63.5%. So NAFLD, it is sinister, but when this sinister pathology of non-alcoholic fatty liver disease is associated with the inflammation, that makes it the non-alcoholic steatohepatitis, and the percentage of non-alcoholic steatohepatitis in patients having undergone biopsy is as high as 63.5%. 2/3 of the patients of non-alcoholic fatty liver disease have non-alcoholic steatohepatitis. It is that bad. So now going on to the diagnosis of non-alcoholic fatty liver disease. Well, history, patient is usually asymptomatic. I mean, patient would come with a typical complaint of having dyspepsia in many cases, early satiety, frequent dyspepsia, incomplete evacuation, and so on and so forth. But you really need to press in and get the details from the history. Incidental finding of liver enzyme abnormalities or steatosis on imaging, exclusion of intake of significant amount of alcohol and other secondary causes of fatty liver are an important part of your diagnostic armamentarium. Detailed physical examination, assessment of the body mass index, as I was talking about, but I hope you realize that your body mass index is not an accurate measure. Let us be very simple. Now, I am a 5 feet 9 inches person. I believe John Abraham has a height same as mine. Now, my weight is approximately 80 kgs. Now, John Abraham has also a weight of approximately 80 kgs. So, if we calculate, so my BMI and John Abraham's BMI is the same. Now, are we equally fit? I'm pretty sure not, because John Abraham has the mass in the biceps and the triceps, where I unfortunately have my mass in my abdominal fat. So in spite of the fact that me and John Abraham would be having a similar body mass index, we need to understand that we have very different scenarios. I have abdominal obesity. That person doesn't have abdominal obesity. His lean body mass and my lean body mass are completely different. My risk of insulin resistance, my risk of developing non-alcoholic fatty liver disease, my risk of developing non-alcoholic steatohepatitis, my risk of developing dyslipidemia, my risk of developing type 2 diabetes mellitus, my risk of developing cardiovascular disorder is so much higher than a certain John Abraham, in spite of the fact that both of us might be having very similar body mass index. So waist circumference, waist to hip ratio are very, very, very important aspects. We should not confine our understanding through the BMI. Yes, BMI is very simple, BMI is very easy to calculate. We will understand that if the patient walks into your clinic and you take the body weight, and even in my clinic, if I had the opportunity of rotating the camera and to show you around my clinic, I mean, it's very easy to get the BMI done. Actually, in a very heavy, crowded chamber, very difficult to actually assess the waist to hip ratio. It takes a lot of time, you need a lot of effort. Actually understanding where to measure the waist circumference, where to measure the hip circumference. In fact, measurement of the hip circumference is not a very detailed method, but that waist to hip ratio, understanding the implication of the waist to hip ratio and waist circumference is very, very important in ascertaining the abdominal obesity and understanding the patient who is at a higher risk of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Always understand that such metabolic derangements is a basket. It's like a buffet. When we go to an expensive restaurant and attend the buffet, it's not an a la carte. So similarly, a patient with a metabolic syndrome or suspected metabolic syndrome, understand this. It is not only the non-alcoholic fatty liver disease, it is not only the dyslipidemia, it is not only the hypertriglyceridemia, it is not only the abdominal obesity, it is not only the type 2 diabetes mellitus. In case of a female patient, it's not only the polycystic ovarian disease, but this entire gamut of the insulin resistance needs to be addressed properly. So diagnosis of NAFLD, imaging studies would include the ultrasonography, the CT scan or MRI. These are accurate in the detection of moderate to severe hepatic steatosis at good hands. Liver function test, also understand that even in the ultrasonography report, just mentioning that mild fatty liver, unfortunately something that I find on a day-to-day basis in our clinic is not the way to go. The alteration of the hepatic ecotexture comments on the steatosis, comments on the architectural pattern of the liver sinusoids is of utmost importance in the ultrasonographic description, which will help you guide further. Your liver function test report will help you guide further, and because obviously you cannot recommend hepatic elastography in all patients. You definitely cannot recommend liver biopsy in all patients, although liver biopsy is the gold standard for diagnosis. That is why very detailed history taking, understanding the scenario of the diabetic patients, how bad or how well controlled the diabetes control is, if the patient is at all diabetic, understanding the control of the hypertension, understanding the dyslipidemia, understanding the patient's weight gain pattern, understanding the patient's, in fact, your markers like the stigmata of insulin resistance, including acanthosis nigricans, including skin tags, including abdominal stretches, all this form an important simple pathway to help you in the diagnosis and proper management of non-alcoholic fatty liver disease. Now, always look for diabetic liver. I was talking about the huge incidence and prevalence of diabetes mellitus throughout the world, as in the Indian scenario. And what we know about the Indian scenario, what percentage of Indian patients have well-controlled diabetes? In India, we were talking about how many patients? 77 million adult patients with diabetics. Now, out of 100 patients, 15 patients have well-controlled diabetes, 1-5. 3 patients have uncontrolled diabetes, but they are at least aware of the fact that they have uncontrolled diabetes. So 15 plus 3 is 18. 32 patients are such who know that they have diabetes, but they are not aware of the fact that they have uncontrolled diabetes. So 15 plus 3 plus 32 is 50. What about the remaining 50? They don't even know that they have diabetes. They are uncontrolled diabetes. They are undiagnosed diabetics. Now, it is that bad. In fact, there's another company which we know with it having the very important landmark trial. The 6-month data of the landmark trial and this 1-year data of the landmark trial is already available in the general purview. Once again, I believe my colleagues would know about which landmark trial I'm talking about. And what does it show? Even among the diagnosed cases of diabetes, 25% have adequately controlled diabetes mellitus. It is that bad in the Indian scenario. So obese, middle-aged females with diabetes mellitus are more likely to have fatty liver changes on ultrasonography, up to 70%. Look at this, 70% of obese middle-aged females. And I agree to it. This is what we see on a day-to-day basis in our clinics. History of diabetes mellitus associated with a 2.6-fold increase in the risk of NASH, non-alcoholic steatohepatitis. So when we are talking about NASH, non-alcoholic steatohepatitis, the patient not only has non-alcoholic fatty liver, but along with that, the patient has proven evidence of hepatocyte inflammation. We talked about that. We talked about the ballooning degeneration. We talked about the Malpighi's bodies and all that. And diabetes and body mass index are associated with the fibrosis progression. So diagnostic algorithm in a diabetic patient, how do you go ahead? Well, your patients with pre-diabetes or type 2 diabetes, this is important, pre-diabetes. Always note that even in the patient with pre-diabetes, what we know pre-diabetes is a condition in which the patient is expected to have a higher chance of developing diabetes. Criteria wise, pre-diabetes fasting value between 100 and 125, postprandial blood sugar between 140 and 199, and HbA1c between 5.7 and 6.4%. Now, such a patient, always note, even in the patient of pre-diabetes, is approximately 50% reduction of the beta cell function. We are not talking about beta cell mass because that's an area of concern and area of conjecture. And when the patient has a diagnosis of type 2 diabetes mellitus, 50 to 80% reduction in beta cell function has already occurred. That is why the patient is now diabetic. If the ALT or the ultrasonography is abnormal, well, you go for transcranial elastography or MRI elastography or fibrosis biomarker panel. In such a case, a very important aspect would be, if the ultrasonography is abnormal, that hepatic elastography, very important tool. If there is a low risk of fibrosis, periodic evaluation, but understand this, in such a case, if there is a low risk of fibrosis, you are not supposed to put the patient on pharmacotherapy, including but not limited to ursodeoxycholic acid or obeticholic acid. This is what we are trying to highlight. Yes, lifestyle modification is a very important part of the treatment in that patient as well. If there is intermediate fibrosis risk, that patient should undergo liver biopsy, because non-alcoholic steatohepatitis has to be ruled out in such a patient. If there is a high risk of fibrosis, no longer liver biopsy is needed. So if there is low risk, no need of biopsy, standard evaluation, routine evaluation, lifestyle modification, diabetic control, dyslipidemia control, hypertension management. High risk of fibrosis, well, you don't need to do a liver biopsy. The patient has high risk of fibrosis, patient should be on lifestyle modification along with pioglitazone treatment, and we will talk about pioglitazone. In fact, pioglitazone, it is a drug we physicians who practice endocrinology, we do know that pioglitazone has been made a scapegoat for very long. At a point in time, for a very short period, we know even it was taken off the market. Pioglitazone till date is the only pharmacological agent with biopsy proven benefit in management of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Yes, now we have good amount of data pertaining to empagliflozin, we have data pertaining to dapagliflozin, we have data pertaining to exenatide, we have data pertaining to liraglutide in the management of non-alcoholic steatohepatitis, we have data pertaining to ursodeoxycholic acid, we have data pertaining to our area of concern, that is obeticholic acid. But the role of pioglitazone is very, very important even in patients of high risk of fibrosis, and this is something I would want to highlight. Moving on. So overall incidence of advanced fibrosis in diabetic population versus general population, as we can clearly see, much higher in the diabetic population compared to the general population. Whether you look at the plasma ALT or a CT value or liver ultrasonography or HMRS, whatever you look at, it's higher in the diabetic population compared to the general population. And then what is the spectrum? And this is the spectrum we are talking about. So fatty liver, that is steatosis, whereas the basic pathophysiological basis is the insulin resistance. Systemic and hepatic desensitization of the insulin signaling pathways, followed by the NASH, that is along with steatosis, there is hepatitis, that is steatohepatitis, and I repeat, you have inflammation, you have cytokine disbalance, you have oxidative stress, you have hepatocyte apoptosis. We were talking about the ballooning degeneration, the very classic description that we find in the histopathological examination. In fact, my wife is a pathologist. Like, we keep on discussing about the findings of liver biopsy in cases of non-alcoholic steatohepatitis, malodorous degeneration, as we know, and subsequently fibrosis, and that is a point of no return. If your patient has very significant of fibrosis, that is a point of no return. No amount of lifestyle modification, no amount of pharmacotherapy is going to bring your patient back from the state of fibrosis. The patient is going to in the direction of having cirrhosis with a very, very, very bad prognosis. So it is the NASH where you can do something about it. If your patient has moved on to the state of fibrosis, unfortunately, that is a point of no return. Once again, area of concern, an area where much research is being undertaken. It's an area of debate as well. I'm definitely not an expert on discussing about this area. It would be an area of a very senior hepatologist, but in very simplistic term, we are getting the patient at this first stage of fatty liver steatosis. Not only that, in certain cases, even if the patient doesn't have fatty liver, we do understand the risk factors at play. So this is where we physicians have a very, very important role to play, not only after the diagnosis of fatty liver, not only after the diagnosis of non-alcoholic steatohepatitis, but even without fatty liver, when the patient is presenting with the risk factors, the role of the primary care physician is of utmost importance. The pathogenesis of non-alcoholic fatty liver disease, the two-hit hypothesis, this we keep discussing about. I mean, this is the Upteen seminar probably where we are discussing the two-hit hypothesis. So the insulin resistance is responsible for the reduced hydrolysis of triglycerides, which lead to the increased intercellular accumulation of the triacylglycerol. This is a reversible process and comprises the first hit. It's a reversible process. This term is very important. This is a reversible process. Well, what about the second hit? This condition increases the likelihood of developing the molecular and metabolic liver disorders after a second hit of the oxidative stress and the cytokine induced damage. So the cytokine induced damage would be the area of steatohepatitis. The moment that cytokine induced damage, inflammation, steatohepatitis, itis we know indicates inflammation, and after that, well, if the patient passes off into fibrosis, well, it's a point of no return, right? So laboratory investigations. The lab investigations, the liver functions test, mildly elevated transaminases ALT more than equal to AST or gamma glutamyl transpeptidase. However, majority, more than 79% of patients have a normal ALT, and always note that the liver function test is not a good indicator of non-alcoholic fatty liver disease. So the blood test. Now, one thing I would try to dissuade from and not agree with it is the HOMA-IR. Understand once and for all. I mean, this is a very bad habit, or in certain cases of prescribing HOMA-IR. Understand this, sir. HOMA-IR is a research tool. In your clinic, in your IPD practice, in your OPD practice, you should not advise HOMA-IR. HOMA-IR is a research tool. You are not here to diagnose insulin resistance. This is not something we should be doing. Our standard tool, no guidelines, be it the ADA guidelines, be it the AST, be it the ADASD consensus statement, be it the Endocrine Society position statement, be it the Canadian Diabetes Association statement, be it our own RSSDI recommendation, be it the NICE guidelines, which I am a big fan of, would recommend HOMA-IR. Please do not advise HOMA-IR in your patients. It will help you in assessment of insulin resistance, but it's a research tool. It is not for routine clinical practice. But yes, HbS-AG, anti-HCV, lipid profile, the entire glucose tolerance test, fasting, the PP, these are the assessment of the lipid profile in female patients. If you get an evidence of polycystic ovarian disease, such areas are very important aspect that you need to look at. We also know that certain collagen vascular disorders are very important associations with your non-alcoholic fatty liver disease. Looking at the serum iron profile. Why? To rule out hemochromatosis. Serum ceruloplasmin. Why? To look at Wilson's disease. Celiac disease workup. Anti-TTG. Anti-tissue transglutaminase IgA specific. That is the gluten enteropathy that we are talking about. And the celiac disease profile as well. These are very important aspects. Autoimmune markers like ANA, the ANA full profile, Hep2 assay and all that. So non-invasive test of fibrosis, transient elastography, as we're talking about. There are other issues, but we'll stick and try to evaluate transient elastography and hepatic elastography, which is a very important aspect because it has really made our job much easier. To approach a case of non-alcoholic fatty liver disease very scientifically, to approach a case of non-alcoholic steatohepatitis very scientifically, transient elastography is the only imaging modality that can detect liver fibrosis. It gives the measurement of liver stiffness, which correlates well with the degree of fibrosis. So indications of liver biopsy. At the end of the day, I'm very sure everyone attending this session like me are very afraid of prescribing liver biopsy. But note, it's a gold standard of diagnosis of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. It's the only useful modality for assessing the severity of the disease in patients with non-alcoholic fatty liver disease. So do you advise liver biopsy in all patients? No, definitely not. What are the indications for liver biopsy? Age more than 45 years, female gender, AST-ALT ratio more than equal to 1, high AST to platelet ratio index, diabetes mellitus or metabolic syndrome, high NAFLD fibrosis score and high liver stiffness measurement. But what did we look at? Our previous slide would be much more important. Moderate stiffness, moderate risk of fibrosis would be the ideal indication for liver biopsy. And what is the histological definition of the adult NASH? Yes, combination of the three lesions of steatosis, ballooning and lobular inflammation. The moment there is lobular inflammation, the malodorous degeneration, well, that is a sine qua non of hepatocyte degeneration, inflammatory degeneration, and would comprise the diagnosis of non-alcoholic steatohepatitis if found in the patient of non-alcoholic fatty liver disease. The NAFLD activity score or NAS. Well, what are the criteria? Steatosis, depending on the category of definition, we know it's more, if it's more than 5%, then and only then it becomes significant steatosis. If it's less than 5%, in any case it does not qualify, because then in that case it is simple steatosis. If there is hepatocyte or ballooning degeneration, it is added to the criteria. Sign of inflammation, of course, added to the criteria. The total score, if the fibrosis is 0, no fibrosis. If it's 4, cirrhosis. This is the NAS-NAFLD activity score. Important aspect to categorize liver fibrosis in patients of non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, and try and understand which patient is a patient of cirrhosis, which patient is a patient of non-alcoholic steatohepatitis, which patient is a patient of non-alcoholic fatty liver disease. So the diagnosis of non-alcoholic steatohepatitis, NAS score of more than or equal to 5 with steatosis and ballooning degeneration. Lower NAS scores in the presence of steatosis and ballooning also indicates non-alcoholic fatty liver disease, non-alcoholic steatohepatitis. Now, management of NAFLD, well, be very clear about this. The first line, lifestyle modification. The management of non-alcoholic fatty liver disease is lifestyle modification. No matter whether the topic of discussion is obeticholic acid, whether the topic of discussion is liraglutide, whether the topic of discussion is ursodeoxycholic acid, whether the topic of discussion is pioglitazone, whether the topic of discussion is empagliflozin, whether the topic of discussion is dapagliflozin, forget about everything else. The first line and the very, very important management of non-alcoholic fatty liver disease is lifestyle modification. Exercise regimen for a minimum of 45 minutes, 5 days per week, approximately 150 minutes per week. Achieve a target heart rate of 60 to 70% of the maximal heart rate. Exercise can include brisk walking, jogging, or rhythmic aerobic exercises. Weight reduction, very, very important aspect. Similarly, when we used to ask questions, what is the first line management of a case of polycystic ovarian disease? The first line management of a case of polycystic ovarian disease is weight loss. First line management in a patient of non-alcoholic fatty liver disease is lifestyle modification. So this is what I'm trying to highlight as a junior colleague of yours. If your patient has a diagnosis of non-alcoholic fatty liver disease, if your patient has anything related to insulin resistance, or first advice, exercise, lifestyle modification, weight reduction, 10% of the body weight to be reduced in 6 to 8 months. No matter, we now have newer GLP-1 analogs, we now have oral GLP-1 analogs are everywhere. The first line management of NAFLD is lifestyle modification. In fact, the first line management of type 2 diabetes mellitus is lifestyle modification. As we can see, lifestyle modification is the cornerstone of NAFLD management. Percentage of weight loss associated with histological improvement in NAFLD, as you can see, weight loss more than 10%, Look at the fibrosis regression. Fibrosis regression, 45% of patients will have fibrosis regression. NASH resolution, weight loss more than equal to 7%, 4 to 90% of patients will have NASH resolution. Weight loss more than equal to 5%, ballooning inflammation, 41 to 100% of patients will have a reduction of the ballooning inflammation. That is what we are saying. Even NASH is reversible. After the patient goes into bad case of fibrosis, it is no longer reversible. Steatosis, steatohepatitis, a significant percentage of patients would have a reversal, as you can see. And now, pharmacotherapy of non-alcoholic steatohepatitis. Probably this entire thing that we're discussing till now was a prologue to this. This would be a very important aspect of our discussion. Indications of pharmacotherapy in a case of non-alcoholic steatohepatitis. Non-alcoholic steatohepatitis with significant fibrosis, stage F2 and higher. Early stage non-alcoholic steatohepatitis with increased risk of fibrosis progression, age more than 50 years, diabetes. So diabetes with NASH, I believe very significant proportion of our patients of NASH would also be having diabetes. Metabolic syndrome and increased ALT. Active NASH with high necroinflammatory activity is also an indication of pharmacotherapy of non-alcoholic steatohepatitis. Pharmacotherapy is not recommended for bland steatosis, simple steatosis, less than 5% involvement as we call it, and NASH with no or minimal fibrosis. In such cases, stage 0 or 01, there is no indications of pharmacotherapy, but there is every indication of lifestyle modification. Placebo-controlled randomized controlled trial have tested drugs for non-alcoholic fatty liver disease as an add-on to lifestyle modification, demonstrating better response with lifestyle modification plus pharmacotherapy compared to lifestyle modification alone. So what are the drugs for the pharmacotherapy of non-alcoholic steatohepatitis? Vitamin E, what is the role? Pioglitazone, we did talk about the role. And they are recommended for patients with non-diabetic non-alcoholic steatohepatitis. But pioglitazone, of course, is a very important role. And the other drugs? Well, the other drugs are ursodeoxycholic acid, metformin, pentoxifylline, that's an antifibrotic agent as we know, angiotensin antagonist, long-chain polyunsaturated fatty acids, and fibrates. So what are the effects of intervention in non-alcoholic fatty liver disease? Well, lifestyle modification. Everywhere there is importance. In weight loss, yes. Insulin resistance, yes. Improvement in liver enzymes, yes. Inflammation, that is non-alcoholic steatohepatitis, yes. Fibrosis, well, questionable. The moment that the patient has significant amount of fibrosis, your lifestyle modification probably is no longer going to work that well. Vitamin E. Well, vitamin E, some role in inflammation, non-alcoholic steatohepatitis, but no role in weight loss, no role in insulin resistance, improvement of insulin resistance, no role in fibrosis as well. Pioglitazone. Problem with pioglitazone would be weight gain. In fact, there is fluid retention. Rather than the weight gain, there is fluid retention. In fact, we can go on and on infinitely regarding the weight gain of pioglitazone. It's in pioglitazone, it's the adipocyte differentiation which is at work, where the luminal adipocytes are changed to the submucosal adipocytes. But that's another area, not really our area of concern now. Insulin resistance, yes. In fact, the only drug acting against insulin resistance, not even metformin, would be pioglitazone. It's an insulin sensitizer. Liver enzymes improvement as well, and inflammation. And there, in fibrosis, even in fibrosis, pioglitazone might be beneficial. There is conflicting report pertaining to the same. Ursodeoxycholic acid, well, similar, might be beneficial in fibrosis. Metformin, not beneficial in fibrosis, but as far as insulin resistance and weight loss goes, there is improvement. Of course, we know that technically metformin is not considered an anti-diabetic agent producing weight loss. In fact, the only two anti-diabetic agents with proven weight loss would be the GLP-1 agonist and the ACE-02 inhibitor. Not metformin. Metformin is considered weight neutral. DPP-4 inhibitors are also considered weight neutral. Only the GLP-1 agonist and the ACE-02 inhibitors are drugs in diabetes mellitus producing weight loss or significant weight loss. Now, saroglitazone, that's an Indian molecule. As we know, it's a novel dual PPR alpha gamma agonist for NFL NASH and a phase 2 RCD. Data from the evidences 4 study. So saroglitazar, as we know, it's a novel dual regulator. It's an Indian molecule. Saroglitazar, what is the conclusion from this? Saroglitazar 4 mg significantly improved the serum ALT, hepatic steatosis, insulin resistance, and dyslipidemia in patients with non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. In fact, we now know that very recently DCGI has provided approval of use of saroglitazar in NAFLD NSH. It's an Indian molecule, obviously US FDA approval and European Medicine Agency EMEA approval is yet to be available, but DCGI approval for saroglitazar in diabetic dyslipidemia and diabetes associated non-alcoholic fatty liver disease and non-alcoholic steatohepatitis is now available. Saroglitazar, the first GTazar to be approved in India 2013. Indication diabetic dyslipidemia or hypertriglyceridemia in type 2 diabetes mellitus not controlled by statins alone. PPR alpha activation activates genes on the lipid metabolism, increases the fatty acid oxidation, decreases the triglyceride and VLDL, and improved lipids, produces better glycemic control and lesser inflammation. Well, cardiovascular event reduction, as we know, we still don't have a dedicated CVOT trial, cardiovascular outcome trial with saroglitazar. We do not have a dedicated study like, say, a Canvas or a Saver-TIMI or a EMPA-REG or a Carolina Carmelina like we have for the newer anti-diabetic agents. We don't have a dedicated cardiovascular outcome trial for saroglitazar. So exact evidence regarding reduction of events, cardiovascular events, the 3 PMAs as we call it, the major adverse cardiovascular events, that is cardiovascular death, non-fatal MI, non-fatal stroke. We now also try to test for the heart failure with reduced ejection fraction, admission due to heart failure. Such dedicated cardiovascular outcome trial for saroglitazar is not there, but regarding the indication for diabetic dyslipidemia and diabetes associated non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, there is a recent DCGI approval for the same. Obeticholic acid, the first in class and selective farnesenoid X receptor agonist, stimulates the FXR 100 times more intensely than cyanodeoxycholic acid. High selectivity with minimal activity to the other receptors, has anti-cholestatic and hepatoprotective properties, approved for the use in primary biliary cholangitis. Kindly note that it's previously called the primary biliary cirrhosis, now called the primary biliary cholangitis. Be it ursodeoxycholic acid, be it obeticholic acid, the primary indication was the primary biliary cirrhosis. But we are looking at its role in non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. We have already talked about the specific areas of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, where along with lifestyle modification, your pharmacotherapy is an important aspect of the management. So it's a promising option for NAFLD and other liver disorders. The effects are mainly expressed in various tissues including the liver, the intestine, the kidney and the adrenal gland, and to a lesser extent in the adipose tissue and heart. Beneficial effects on various metabolic disease include fatty liver disease, type 2 diabetes, dyslipidemia and obesity. The systemic effects of the FXR, the farnesenoid X receptor, cholestasis, liver fibrosis, alcoholic liver disease, non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, liver regeneration, hepatocellular carcinoma. In the intestine, it reduces the bacterial overgrowth, mucosal injury, tumorigenesis, glucose homeostasis. In the kidney, it reduces the risk of diabetic nephrotoxicity of the anti-cancer agents like cisplatin and cyclophosphamide. FXR expression in the brain but not in the glial cells. In the breast tissue, reduces the risk of tumorigenesis leading to non-small cell lung cancer and breast cancer. Reduces the risk of lipotoxicity. The fatty pancreas, as we call it, pancreatic exocrine insufficiency, which is an important aspect of the FCPD patients, and reduces atherosclerosis and reduces platelet activation in the cardiovascular system. So in liver, what is the role of the obeticholic acid? Well, decreases liver fibrosis, decreases liver inflammation. We found that pioglitazone has a role like this. A very similar role in obeticholic acid, the FXR receptor activation. So mainly acts to the pleiotropic effect. So pleiotropic, what is pleiotropic? All of a drug's action other than those for which the agent was specifically developed, that is actions apart from the primary action for which the drug was developed. It may include adverse effects which are detrimental ones, but is often used to denote additional beneficial effects. Obeticholic acid, which is an effector receptor agonist, was developed for its action on the inhibition of bile acids. So the primary indication was the primary biliary cholangitis. It was not developed for NFLD, it was developed for primary biliary cholangitis. But the pleiotropic action of obeticholic acid is of utmost importance in the management of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. However, obeticholic acid also has other effects, and these are the systemic of the pleiotropic effects. So it reduces hepatic ballooning, reduces hepatic steatosis, reduces hepatic inflammation, that is the aspect of the non-alcoholic steatohepatitis, decreases the oxidative stress, decreases fibrosis, and this is very important. Hardly a few drugs and hardly a few modalities would decrease fibrosis after a certain stage. Obeticholic acid reduces the risk of fibrosis and decreases oxidative stress. The pleiotropic effects of obeticholic acid: it reduces gluconeogenesis. So which drug does the same? Metformin does the same. Formation of glucose, but metformin reduces hepatic gluconeogenesis. It increases the glycogen synthesis, conversion of glucose to the storage form of glucose, that is glycogen, reduces fatty acid, reduces triglyceride synthesis, reduces cholesterol level, reduces fatty acid oxidation, reduces inflammation, reduces lobular inflammation or hepatitis, reduces the progression of the non-alcoholic steatohepatitis, reduces oxidative stress, the free radical mediated damage of the liver, the cytokine mediated damage of the liver, reduces the risk of apoptosis, reduces the pro-apoptotic genes, increases the anti-apoptotic gene. These are the genes which reduce cell death or promote cell survival, reduces the TGF beta signaling, reduces the risk of fibrosis. In certain cases, although limited data is there, reduces the risk of fibrosis related damage. Regenerate study. NASH, regenerate is the acronym for this clinical trial. Non-alcoholic steatohepatitis represents an important unmet medical need worldwide, increasing cause of liver-related morbidity and mortality, anticipated to become the principal indications for liver transplant in the US by 2020. Currently lacks FDA-approved pharmacological therapies. The OCA, that is obeticholic acid, is an effector agonist with preclinical activity against non-alcoholic steatohepatitis. Now, current details: 18-month-old interim analysis of the randomized controlled trial stage 3 comparing efficacy and safety of obeticholic acid at 2 doses versus placebo in patients with non-alcoholic steatohepatitis and liver fibrosis. And at the end of it all, we still know that although a lot of data has been generated, we do not have a lot of clinical trial, because randomized clinical trial are the highest level of evidence in evidence-based medicine. In fact, the highest level of evidence, as we know, is the systematic review and meta-analysis. And so systematic review of multiple randomized controlled trial is of course the highest level of evidence. Randomized controlled trial are one of the high level of evidence, grade 1B. So what data do we have from this? Well, done in 2,480 patients, randomized into 1:1:1. One third of the patients would be on placebo, one third of the patient would be on obeticholic acid 10, one third of the patients on obeticholic acid 25. At 18 months, what is the interim analysis showing? Well, you had two primary endpoints. The primary endpoints were fibrosis improvement by more than or equal to 1 stage with no worsening of the non-alcoholic steatohepatitis. So fibrosis improvement without worsening of the inflammation, or NSH resolution, that is resolution of the inflammation with no worsening of fibrosis. So what is the percentage that we see? Well, clinical benefit defined as showing superiority over placebo. So it's a superiority trial rather than a non-inferiority trial in delaying disease progression as evaluated by progression to cirrhosis, reduction in the hepatic decompensation events, change in the MELD score, that is model for end-stage liver disease score, from less than or equal to 12 to more than or equal to 15, liver transplantation or all-cause mortality. Well, treatment with obeticholic acid, very clear data from the regenerate study, which is a randomized controlled trial. Decrease in liver fibrosis, decrease in histological features of steatohepatitis, improvement in liver biochemistry, and overall improvement adverse effect profile similar to previous studies. So safe drug, efficacious drug. in very simple terms. Investigators concluded that the Regenerate represents the first successful phase 3 trial in patients with non-alcoholic steatohepatitis. Study is ongoing to confirm clinical outcomes. It's an 18-month interim analysis. The final results are yet to be out in the open purview. FXR receptor ligand obeticholic acid for non-cirrhotic, non-alcoholic steatohepatitis. FLINT study. What is the FLINT trial background? FLINT was sponsored by the National Institute of Diabetes and Digestive and Kidney Disorders, conducted by the CRN group, the same COVID group that concluded the PIVENS trial. More than 50% of the NASH patients in the FLINT trial had comorbid type 2 diabetes, as expected. Importantly, 1/3 of the obeticholic acid treated patients had advanced fibrosis, F3 bridging fibrosis, as we noted. Therefore, the NASH population studied in FLINT had markedly more advanced disease than the non-diabetic NASH patients studied in the PIVENS trial previously. Objective: to assess the efficacy of the obeticholic acid in adult patients with non-alcoholic steatohepatitis. Treatment: obeticholic acid orally 25 given or placebo for 72 weeks. Obeticholic acid 141, placebo 141. And what is the data? The obeticholic acid was superior to placebo for improvement of liver histology. Fibrosis improvement by at least one stage. Look at the p-value. P-value is significant, less than equal to 0.05. Additionally, significant obeticholic acid treatment effects were demonstrated on the major histological features of non-alcoholic steatohepatitis, including steatosis. Look at the p-value. It is statistically significant. Glomerular inflammation, once again a statistically significant p-value, and hepatocellular ballooning. In fact, these two were the sine qua non of the hepatocyte inflammation, as we were talking about in the first or second slide. Histological improvements were consistently greater in patients with more advanced disease and at greatest risk of progressing to liver failure and death. Obeticholic acid was generally well tolerated. We found that the adverse effect profile was comparable to the placebo. It was very similar to the previous studies. Only issue was pruritus, occurring more frequently in the obeticholic acid treatment group. It's a drug acting against cholestasis, so some degree of pruritus is a part of it. But essentially, we do understand with a very significant improvement in fibrosis, significant improvement in the ballooning degeneration, significant improvement in the overall inflammation, significant improvement in the fibrosis score. And we are not talking about patients with early fibrosis, we are talking about patients with significant fibrosis. Even in such patients, statistically significant improvement was found in the FLINT study. So, liver fibrosis is considered the leading prognostic factor among patients with non-alcoholic fatty liver disease because of its strong correlation with survival rate and liver-related outcome. And the different studies with obeticholic acid, be it the study of Mudaliar and all in diabetes and NASH patients. Look at this 6-week study, an increased insulin sensitivity by 24.5% as measured by the HOMA-IR scan. The FLINT study, as we discussed, the Regenerate study, we have discussed both of them in detail, and evidence was with the obeticholic acid 25 gram. The control study from 2019, once again showing mostly owing to large less atherogenic LDL particle. At week 4, even in the control study, the obeticholic acid had an increase from baseline in the HDL. 1 minute. So, comparison of the current treatment options of NAFLD and non-alcoholic steatohepatitis: the obeticholic acid, saroglitazar, and vitamin E. Now, in primary biliary cholangitis, where the primary indication of obeticholic acid is primary biliary cholangitis, that is why it was approved, that is why it is achieved FDA approval, not with vitamin E or saroglitazar. In fact, we found that vitamin E has no role in weight reduction, no role in improvement in insulin resistance. Improvement in fibrosis. Well, as we found from the Regenerate study, as we found from the FLINT study, improvement in fibrosis with obeticholic acid, but not with vitamin E. NASH resolution. Well, non-alcoholic, that inflammation was reduced by obeticholic acid, inflammation reduced by saroglitazar, as also by vitamin E. Decrease in the lobular inflammation. Now, that is found in obeticholic acid and saroglitazar, but not with vitamin E. What about the HbA1c reduction? Of course, saroglitazar is an anti-diabetic agent. You expect HbA1c improvement with the saroglitazar. What about the NAS score? We found that there was improvement in the NAS score. We found that NAFLD assessment score, improvement in the NAS score with all three of them. Improvement in steatosis, improvement in ballooning degeneration found in all three. So, all in all, as we call it, obeticholic acid ticks all the right boxes. What about the biochemical parameters? Well, alkaline phosphatase, ALP, and total bilirubin, and ALT, and AST, and GGT, and liver stiffness, and triglycerides, and BMI. Improvement once again, obeticholic acid ticking all the right boxes. So we'll summarize now at the end of a slightly lengthy discussion. So the non-alcoholic steatohepatitis is the major concern across the globe, as major indication of liver transplant waitlist patient in US are due to non-alcoholic steatohepatitis, and it's increasing day by day compared to other causes of the liver disease like hepatitis B and hepatitis C and other disorders, and be it a Wilson's disease, and be it hemochromatosis, be it the autoimmune hepatitis and all that. And rather than that, it is the non-alcoholic steatohepatitis and subsequent fibrosis, which is the major indication of liver transplant. Prevalence of non-alcoholic steatohepatitis is more in the diabetic population than general population. Hence, diabetic population are at an increased risk to develop NAFLD or NSH. Lifestyle modification remains the first preference in the management of non-alcoholic steatohepatitis. However, every patient should be assessed for fibrosis periodically through the MR elastography or transient elastography or the fibrosis biomarker panels. Patients who develop fibrosis due to non-alcoholic steatohepatitis may be treated with obeticholic acid to reverse the fibrosis score. Obeticholic acid also improves insulin sensitivity in patients with diabetes mellitus and non-alcoholic fatty liver disease. Control of other cardiovascular risk factors like the glucose level, fasting, and the PP and the HbA1c, blood pressure, lipid, triglyceride. In fact, the entire lipid profile are also equally important, but it is the triglyceride which is an important aspect of the metabolic syndrome and the major contributor to the non-alcoholic fatty liver disease. Of course, it is the LDL that is the contributor to the cardiovascular disorder and cardiovascular death and stroke and MI, as we know, but it would be the triglyceride which is the major contributor, the major metabolic contributor to the development of non-alcoholic fatty liver disease. We are at the end of our discussion. Thank you so much, and we are now open to take questions.